Off the program, and it's my real pleasure to introduce Dario Palladini, who will be talking about optimizing color Doppler in fetal cardiac screening and diagnosis. And for many of you who know Dario, who's to me, I remember training in obstetrics, starting off in the area of prenatal diagnosis. It was Dario's textbook of fetal anomalies. To me, that was a complete eye-opener because it was a textbook in a sense that made things very practical and what you see in a day-to-day, and it still, to me, stands out as being one of the golden Bibles of screening and diagnosis of fetal malformation. And I gather in the pipeline that there might be another edition coming out soon. So keep your eyes posted for that. Dario is an obstetrician gynecologist and has been, again, very involved with ISOUG, like many of us, but Dario's involvement with ISOUG goes back well to the early days of the foundation and has been chair of education for many years in the past, a board member in the past, and has had several awards, including the Stuart Campbell Award of Education, which is probably one of the most prestigious awards issued by ISOUG. So without further ado, I'll hand over to Dario to kickstart the first lecture. Thank you.
Good morning to everybody. It's a pleasure to be here in Dublin with you this morning. And I should like to thank Simon and Fionnuala for this kind invitation. It's a pleasure to be here today. And also I would like to thank Simon for the kind words regarding my the third edition of our book. So the message of this first talk regards technology, how and the methodology, how you should try not to catch up, as I highlighted in my title slide, about the use of color Doppler and power Doppler, both in for screening purposes and for advanced examination. A disclosure, because most of the pictures that you'll see in this talk, as well as in other talks of mine across these 2 days, are coming from the last release of the third edition, which has come out of print in June. So it's 3 books in one. It was dubbed like that because you have a thick neurosonal part, a thick fetal echo part, which may also work as a standalone text for fetal cardiology, and all the remaining malformation were dealt with thoroughly as well. So if you are interested, please go online and you can find it on Amazon or anywhere. So what happens when you push and switch on your color button? This is the feeling that have some beginners or some residents, but not only, maybe some also older person who do screening sometimes have this kind of feeling. And this is what happens. Let's hope that it will be okay, because you change machine, you change the way of approach, you change patient, and then say, okay, let's hope it will work. But actually, it is us who should say and find a way to interact with that patient, that depth of intonation, and that examination. So this is why. As far as the fetal echo is concerned, the top priority is, of course, to keep a high frame rate because of the fast heartbeat, which is 160, 180 beats per minute, as you know. So high frame rate means exceeding at least 18, if not 20 hertz, okay, which is image per second on the screen. And the 3 most relevant features that you may use to achieve that is to narrow the 2D window, the grayscale one, use a small color box. I will come later to this in a while. And nowadays it's less relevant, but sometimes, especially in obese patient, you may also wish to reduce the number of lines that the CPU of the scanner has to process to increase the frame rate. So what happens when you use a suboptimal color box? This is a color box encircling the whole of the thorax, and you see that the frame rate is suboptimal because it's 14 hertz that you see here. And it takes only 2 seconds to reduce it and to tailor it around the fetal heart, and you see that the frame rate goes up twice, okay, to 32 hertz. So this is a very simple thing, but anytime and this applies cross-sectionally to all other application of color and spectral Doppler in OB ultrasound. So anytime you want to assess anything in color, keep in mind to tailor and to shrink as much as possible the ROI around the fiddle heart. Another important concept regards the so-called PLF, which stands for pulse repetition frequency, which is the relationship between the depth of insonation at which you carry out your Doppler investigation, be it a color Doppler or be it a spectral Doppler evaluation, and the maximum velocity that you may accommodate within your scale on the side of the image before going into the what is called the Nyquist limit. If you reach the Nyquist limit, which is the maximum allowed velocity per depth of insonation, then you have the phenomenon which is called aliasing. Okay, so and this of course relates most of the time with the BMI of the patient. The deeper you go, the lesser velocity you may accommodate in your image, in your Doppler assessment, or the timeline of the spectral Doppler. Okay, this is very important. So, for example, if you have this is my carotid artery just before coming here. If you have 2 centimeters deep investigation, you are allowed to take 23 centimeters, I read it for you, on the color, and 45 centimeters on the spectral Doppler. If you exceed that, then you go into aliasing. Okay, these are the 2 velocity scales that you have to keep in mind. And if you go to aliasing, it means that it reverts the color code or the direction code that you get with your display. Okay, if you have a velocity value which is there, the only way to get it is to increase as much as you can the PRF. If you reach the Nyquist limit and you're still there, what you can do with spectral Doppler is to decrease the baseline. Okay, you decrease the baseline, and then you can accommodate the whole spectral waveform. But if you cannot decrease the spectral the baseline, then the only thing you have to do is to work with PRF. In this case, I increased the PRF throughout these 3 images, and you see that I could accommodate the velocity waveform. But otherwise, you will have this kind of artifacts. And this also applies to color Doppler. This is a left outward tract. You see the ascending aorta. In this case, the PRF was too low. Okay, so at the level of the annulus of the semilunar valve, we have aliasing, and this goes into red. So in that case, it's not really turbulent flow. It was a PRF which was set too low for that kind of examination for you to consider, and that if you increase with your PRF button or knob or whatever on the console of the screen, you get a very smooth and laminar flow, which is unremarkable in that case. So keep in mind how you play and toggle with the PRF. However, unfortunately for us, we do not have only the PRF to keep an eye on while using color Doppler. For example, this is nice for chamber view, but is this so nice? Do you think it's adequately? Of course, if I ask you this question, the answer that comes to your brain and mouth is no. Okay? But why no? Is the color Doppler gain setting is okay? Any hint? Yes or no? Yes, because you do not see any sparkle of red or blue around the image. So the color Doppler is okay. Is the PRF okay? Yes, because there is smooth laminar flow of the 2 inflows, so that's correctly set. But the problem is with the balance. Why? Because you see here that the interventricular septum is completely hidden by the color signal. Okay, so you do not have that kind of anatomical information. This may well be a complete interventricular septal defect. I did not see it. Okay, and this is a balance which is correctly set. So this is one of the most neglected and at the same time most important and relevant functions that you have to be aware of while carrying out your color Doppler examination of the fetal heart. So if you want to enhance and boost your fetal echo and color Doppler fetal echo, you have to keep a balance in your mind, okay? So what is the balance? The balance sets our priority in some scanners is called priority, how much the color Doppler signal should paint over the grayscale one. So if you reduce the balance, you have the grayscale anatomical information to be visible on the screen. If you increase the balance, then you hide it completely below the color Doppler signal. These are four chamber views with different settings of the balance, and you see how it goes from too high because you hide most of the interventricular septum, to adequate, and too low because you have sparkles of gray at the level of the ventricular chambers. So next question is how you set the balance. It's easy. If the vessel that you want to assess is large enough to be seen on grayscale ultrasound, so you do not need the anatomical information, but you have already there on grayscale, then you can set the balance mid to low. So you keep the color within the boundaries of the vessels. Okay? This applies, for example, to the three-vessel trachea view, in which you see the V shape, which is very simple to see. On the other hand, if you want to assess the flow and derive the anatomical information of the connection, for example, between the pulmonary veins and left atrium, because you see the color across them, then you have to set the balance high, because you have to tell to the scanner, okay, I prefer to see the functional information and to derive the anatomical information based on that. Okay? So in this case, you see the venous flow here, and you can derive the fact that there are indeed pulmonary veins entering the posterior wall of the left atrium. And this is another application that I boxed to my internal mammary artery to assess the thymic area if you have a risk of max deletion 22q11, and we come to this later on. This was until 2021 because the latest release of most scanners nowadays will have boosted the feature of a balance. You see, this was a three-vessel trachea view with the former release of the scanner, and this is a three-vessel trachea view with the current release, in which you see how nicely depicted is the septum, well, actually the two walls of the ductal arch and the aortic arch in this case. And the same applies to the veins. This was a clip taken with the previous edition, and you see very nicely the pulmonary blood flow, but you do not see the vein there. And this is the current technology. So with this type of approach, it's very simple and satisfying for us to look at these vessels. And then you can toggle and play with the colors. For example, in some cases, I use a unidirectional power Doppler, just as kind of background contrast to highlight some features, anatomical features of the images and the hearts that I'm assessing. In this case was a transposition, corrected transposition. In this other case was complete AVSD, and you see how nicely the color depicts the whole anatomy here. And the same applies for pulmonary veins. These are two nicely set pulmonary veins entering into the posterior wall of the left atrium. And this is the abdominal counterpart. I will expand on that later in one of my talks regarding a partial form of abnormal pulmonary venous return. But now I checked the balance, I checked the PRF, I checked the wall filter, which I didn't take into account so far, and everything was okay. But I looking at the four-chamber view to seek the pulmonary veins, and still I do not see them. Why? So I get some frustration in my brain. And then there is one very simple and basic function that sometimes when we think about more complicated things, we forget about it. Because several producers of the scanners try to set the factory ones very slightly lower than you should have, because you are less prone to have artifacts and to have color bubbles everywhere. Okay, so play with color and play with the gain of the color and the power. And the way to play with that is just to boost it until you have a thunderstorm of color, and then gradually reduce it until you see very nice and neat flow just only across the vessels that you're interested in. Okay, that's the way to use your color gain. Okay, and then another very important issue regards the initial approach, because the first step towards a good color Doppler investigation has to be taken before you switch on actually the color. Why? Because I need to plan ahead is due to the fact that in the physics that rules the Doppler, which is the Fourier algorithm, you have the cosine of the line of insonation. This means that when you are completely aligned with the vessel, you have the wonderful signal and color. If you are, the more you go towards 90 degrees angle, you get very artifactual imaging, okay? So for cardiac purposes, you could accept only insonation angle up to 25–30%. And of course, this is the opposite that you have with grayscale, because with grayscale, the best things that you see are the ones insonated at 90 degrees because all the ultrasound waves are reverberated towards the transducer. So you have to find a compromise between the two things. So you use your grayscale, you align your insonation with the vessel that you want to assess, and then eventually you switch on the color, only when you are perfectly aligned. That's the way to carry out your color Doppler investigation. Just a very simple example for you to consider, also because the eye always tries to see what the mind already knows, okay? So you expect, for example, the ARSA that Rabbi described brilliantly several years ago, okay? And you know that it depends on the angle of insonation. Okay, this is the technology, the methodology how to look for the ARSA, for the abnormal aberrant right subclavian artery. And of course, if you insonate it with baby facing on the right side, lying on the right side, you have a blue ARSA because the flow will go towards the distant part of the screen. On the other side, if you have a fetus lying on the other side of the body, then you have a red ARSA, because the fetus, the flow will go towards you. And then you should realize that. And the most relevant information in this case is that, for example, if you have a wonderful position for all the rest of the anatomic assessment and functional assessment of the fetal heart, which is a ventral position, so you have the heart in front of you, this is the worst ever position for the fetus to check for the ARSA, because it will be at 90 degrees and will not get any color or power signal across it. So you may have a false negative result, okay? So keep in mind the angle of insonation, because that's very relevant to your imaging. And if you want to change the line of insonation, because as I told you, you have a ventral position and then you have to go on one side or the other, either you ask the patient to roll on the bed, so you insonate across the maternal lateral area of the abdomen, or you may, if it's a convenient position, you just change the position of the transducer across the maternal abdomen from one side to the other, okay? And then you transform a lateral four-chamber view into an apical one, or vice versa. And then in this way, you can have the good technology and good methodology to assess also the most tiny defects, such as ventricular septal defect, and you can assess thoroughly with color Doppler and with power Doppler all the different features of the VSDs that I think Rabbi will cover about that in his talk, or for example, assess more complicated congenital heart defects, right heart lesions, in which you should always assess the functional status of the tricuspid valve, because, for example, in this that may look like a near normal four-chamber view, this was a pulmonary atresia with intact ventricular septum, and this was the corresponding color investigation imaging with significant insufficiency of tricuspid valve, which is expected in case of PAI-IVS. If you do not see such an insufficiency, then you should always think about where does the flow goes from the right ventricle, if it doesn't go across the pulmonary, nor goes back through the tricuspid valve, and then you should find your fistula. Okay, I will skip that for the sake of time. And this is the coronary fistula. And final, very, very important, I told you regarding the balance, yes, regarding the balance, 5 more, okay. Regarding the balance, that indeed today, and unfortunately this is the century of obesity worldwide. So we have to be prepared to scan every day a variable amount of overweight or obese women. And in this case, despite the fact that the scanners are producing much better technology, advancement, and so on and so forth, sometimes you are left with very inadequate approach, especially because several of these women, unfortunately, have also at the same time an abdominoplasty, which is one of the nightmares for us doing scanning, okay? So this is what you get when you use your grayscale imaging, and this is what you may have if you use your color. In this way, you cannot say with reliable certainty or probability whether there are two inflows or one outflow or the other outflow. But if you use your color Doppler and be reminded of the fact that the emission frequency of the color is different from the emission frequency on the grayscale. So if you have already reduced the emission frequency of your grayscale imaging, you switch on the color, and you should again reduce the emission frequency on the color. And the other thing, you should boost your output, because it's obesity it is not an issue with the thermal index and so on and so forth. Boost your output, and then eventually you can get this type of imaging, okay? Two nice inflows and two crossing over of the two outflow tracks. In this way, you derive your anatomical information from the functional one. You can say, okay, at least I have two ventricular chambers, two nice inflows, two outflows crossing over. So, of course, I may miss a VSD, I may miss abnormal pulmonary variance return, but the central part of the cardiac anatomy is ticked for you on your report. On the other hand, if you want to boost your examination, the latest release of these scanners allow us also to see and to peep into the unthinkable until a few years ago. This was a picture of the month last year, I think, in one of my my papers, showing you how you can actually look at the coronary arteries with a modified left outflow tract here. You see the two coronary arteries here, and this is the corresponding clip. It doesn't work, it doesn't matter. So on one side, to use it with low emission to check for obesity patient, and on the other side, to boost the color and power information towards the near future, which is coronary artery investigation. So in conclusion, how to best use it? Optimal planning. Before you switch on the color, you should align your vessel on while you're using your grayscale with the line of intonation as close to zero as possible, without doing that after you switch on the color, because otherwise you flash all over the screen. Prepare to adjust all the relevant functions that I explained to you in this brief talk, and consider that you may use your functional information to derive anatomical ones if you have an issue with acoustic shadowing, mainly obesity, but also, for example, some twins and so on and so forth. On the other side, very sensitive tools, color Doppler and power Doppler, are a plus today for our examination. And thank you so much for your attention.